welcome back to The Explainer. Today, we're diving into a literal masterpiece of biological engineering, and that is human blood. I mean, think about it. Your bloodstream is this incredibly finely tuned machine. It's the essential highway your immune system relies on, it's your body's oxygen delivery network, and it even has this built-in emergency repair system to stop us from bleeding out. But, what happens when this complex machine actually breaks down? Well, today, we're going to visually map out those exact mechanisms.
So, let's kick things off by challenging something you've probably heard a million times. Is anemia actually a disease? The short answer? No, it's really not. People tend to treat it like it's this single, standalone illness, but anemia is actually just a symptom of a much larger underlying machine failure. Technically, it's just defined as a reduced number of red blood cells or reduced hemoglobin. But to truly grasp it, we have to look at the why.
Here's our roadmap for this explainer. 1. Anemia and its 3 distinct mechanisms. 2. The Clotting Cascade. 3. When clotting goes wrong. And 4. Blood transfusion reactions.
All right, jumping right into Section 1, anemia and its 3 distinct mechanisms. We're going to break down the body's red blood cell supply chain. Honestly, stop trying to memorize a giant laundry list of anemia symptoms. Just follow these 3 logical steps because the supply chain really only breaks in one of 3 ways. Step 1. The body simply isn't making enough red blood cells. Step 2. The blood is being lost. Think chronic GI bleeding, heavy menstruation, or acute trauma. The cells being made are totally fine, there just aren't enough left in the tank. Or Step 3. They're being destroyed way faster than the body can replace them. When you understand this logic, rote memorization becomes completely unnecessary. If you know the mechanism, you know the treatment.
Now, it is absolutely fascinating to see how these production failures physically change what the cells look like. On the left side, you've got iron deficiency anemia. Without enough iron, your bone marrow literally cannot synthesize enough hemoglobin, so it pumps out these tiny, pale cells. Clinically, we call them microcytic and hypochromic. But on the right, you have the exact opposite happening. If you have a B12 or folate deficiency, DNA synthesis actually gets impaired during cell division. So the body produces fewer but much larger immature cells. We call those macrocytic.
Let's move to that third mechanism and see how this all builds. Hemolytic anemia is when red blood cells are destroyed faster than they can be replaced. The classic textbook example here is sickle cell disease. Because of an abnormal hemoglobin structure, when oxygen is low, the red blood cells distort into this rigid, misshapen sickle form. And these rigid cells are incredibly fragile, which leads to rapid destruction, or hemolysis. Even worse, that weird shape makes them prone to clumping up, blocking small blood vessels, and causing these incredibly painful vaso-occlusive crises.
Which brings us to Section 2, the Clotting Cascade.
So we've got the supply chain mapped out. Now let's shift over to the body's emergency repair system. This biological engineering is brilliant, and understanding it makes clotting disorders make total sense. When a vessel takes damage, we kick off Step 1, primary hemostasis. Platelets rush to the scene like tiny, overeager EMTs, sticking to the exposed wall and to each other, forming this initial, kind of fragile platelet plug in just seconds. Right alongside that, Step 2 kicks in, secondary hemostasis, or the coagulation cascade. This is a brilliant sequence where clotting factors basically tag team and activate one another, and it all converges on Step 3, converting fibrinogen into a fibrin mesh. This mesh wraps right around that platelet plug, transforming a quick, fragile fix into a highly durable clot.
Okay, get ready, because this right here is one of the biggest aha moments in clinical pathophysiology. The coagulation cascade actually has 2 starting paths. The extrinsic pathway, which is triggered by tissue damage outside the vessel, is measured by your PT/INR labs, and that is exactly why it's used to monitor the drug warfarin. The intrinsic pathway, triggered by damage inside the vessel, is measured by PTT labs, which is why it monitors heparin. Both pathways eventually converge to make that final clot. When you see it visually mapped out like this, you realize you don't have to arbitrarily memorize which lab goes with which drug. It's a direct, logical consequence of exactly where each medication acts in that cascade.
Moving right along to Section 3, when clotting goes wrong.
So, what happens when this delicate system fails? Well, things tend to break in 2 extreme opposite directions. And I want you to hold both of these extremes in your mind at once. On one side, we have bleeding disorders. This is when there's simply way too little clotting happening. On the flip side, we have thrombotic disorders, where there's way too much clotting happening, forming inappropriate blockages inside totally intact, uninjured blood vessels.
Let's look at the too little side of the equation first. Hemophilia is a genetic deficiency of a specific clotting factor, like factor VIII in hemophilia A, and this causes prolonged bleeding, often dangerously bleeding right into the joints. Then you have thrombocytopenia, which just means you have too few platelets. Without enough platelets, primary hemostasis is severely impaired. You'll actually see this visually on the skin as petechiae, those tiny, pinpoint red or purple spots, along with really easy bruising.
Now for the too much side. Inappropriate internal clotting is driven by what's called Virchow's Triad. There are 3 massive risk factors here. Number 1, venous stasis, like sitting on a super long flight or being immobilized in a hospital bed. Number 2, hypercoagulability, which can stem from genetics or even malignancies. And number 3, endothelial damage, like the trauma from a surgical procedure. This perfectly explains why nurses get patients up and walking immediately after surgery, and why they administer prophylactic blood thinners. By doing that, you are directly and aggressively countering 2 of the 3 points of Virchow's Triad.
So the really crucial point here is understanding how these 2 extremes can actually collide. This is the devastating paradox of DIC, or disseminated intravascular coagulation. DIC is a catastrophic complication, usually triggered by something like sepsis or severe trauma. It starts with widespread inappropriate clotting everywhere in the small blood vessels. But this massive clotting consumes the body's platelets and clotting factors so fast that the tank goes completely empty. As a result, the body is utterly unable to clot anywhere else, leading to severe paradoxical bleeding. It is literally the clotting system failing catastrophically in both directions at the exact same time.
Finally, let's wrap up with Section 4, Blood Transfusion Reactions.
Let's explore what happens when foreign elements get introduced into this incredibly sensitive, finely tuned system. If you remember your basic immunology, a blood transfusion reaction is essentially a type 2 hypersensitivity reaction happening in real time. Your red blood cells carry specific surface antigens, primarily from the ABO and RH systems. If a patient with type A blood is accidentally given type B blood, it triggers immediate cellular warfare. The recipient's existing anti-B antibodies instantly recognize those donor cells as foreign invaders and just ruthlessly attack them.
The clinical fallout from this is incredibly fast and very severe. It's known as an acute hemolytic transfusion reaction. Those attacked red blood cells rupture quickly, and they dump massive amounts of free hemoglobin straight into the circulation. This cascade causes immediate fever, chills, and really severe flank pain. In the absolute worst cases, all that free hemoglobin completely overwhelms the kidney's filtration system, which leads to acute kidney injury.
Because these consequences are so dire, there is a totally non-negotiable rule in healthcare. The transfusion must be stopped immediately. This is exactly why type and cross-match verifications are some of the most rigorously double-checked processes in all of medicine. If a patient develops a fever, chills, or back pain within minutes of a transfusion starting, the absolute first step is to stop the flow. You always treat it as a hemolytic reaction until proven otherwise.
All right, let's bring everything we've talked about today together with our core takeaways. By mapping this out visually, we've seen that understanding the underlying mechanics really makes rote memorization obsolete. We learned anemia is a symptom categorized by 3 supply chain failures: production, loss, or destruction. We mapped the brilliant engineering of the Clotting Cascade and saw exactly why intrinsic and extrinsic pathways correlate directly to specific lab tests and medications. We explored the delicate balance of Virchow's Triad, the catastrophic 2-way failure of DIC, and finally, the rapid cellular warfare of transfusion immunology.
You've now got a really solid foundational map of the hematologic system. But, all this blood relies on a pump to actually move it. So I'm going to leave you with this provocative question. How will these intricate blood and clotting systems react when the heart itself starts to fail? That dynamic intersection of systems is exactly what we'll be diving into in our next explainer on cardiovascular physiology. Until then, keep exploring, keep questioning, and I'll catch you next time.